Club meeting.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My dear professors, Dr. Khaled Abdelal, Dr. Omar Farouk, Dr. Adel Absini, let me have the honor to start the first journal meeting of the Egyptian Vascular Club. And my wish, and this is what I wanted to do, always to be a fruitful, scientific, and educative sessions by the material that I will present with the presenters, by the great professor that will take the hand for discussion, especially that we have a lot of professors in our Egyptian Vascular Club, and kindly the three of them are honored us by the attendance of this scientific journal. Let me introduce first of all Professor Khaled Abdelal, my mentor, the professor of vascular surgery here in Egypt, or was in the National Institute of Diabetes, and later he go for France and leave us, then to the UAE and the University. Professor Adel Absini, the professor of vascular surgery in Tanta University. Dr. Omar Farouk, Professor Dr. Omar Farouk, Professor of Vascular Surgery in the General Institute and Teaching Hospital here in Egypt. Today we will discuss a paper about the comparison between surgical and endovascular revascularization for decreasing the incidence of major amputation. And let me to present the presenter. The first one is Dr. Omar Asad, the specialist of vascular surgery in National Institute of Diabetes. The second one is Dr. Khaled Mohammed, senior resident of vascular surgery in National Institute of Diabetes. And my great honor for all of the audience and the attendees. And kindly, Dr. Khaled, you will take the over for introduction of this scientific paper.
Thank you, Dr. Mustafa. First EVC Journal Club meeting. Critical appraisal of a study. Our agenda. Paper summary. Methodology and designs. Patient selection and enrollment, ethical consideration, statistical analysis, key findings of the study, funding resources, points of weakness, points of strength on the study, limitations of the study, conflicts of interest, and conclusion. Paper summary. An international randomized paper aims to determine whether surgical bypass or endovascular intervention was the best revascularization option for people with chronic limb-threatening ischemia with lowering risk of amputations. Methodology and designs. Prospective randomized multicentric open-label trial with 1,830 participants, divided into two cohort studies based on the availability of single segment of great saphenous vein in time frame from August 2014 till October 2018. Cohort 1, patient with adequate single segment of great saphenous vein, whom is about 1,434. Into two groups, surgical. Cohort 2, patients without adequate single segment of great saphenous vein, whom is about 396, into same two previous groups, surgical versus endovascular group. The follow-up was scheduled at 1, 3, and 6 months, and every 6 months for up to 84 months after randomization. Differences in time between first event of minor amputation that affect the patient up to major amputations were evaluated. Patient selection and enrollment. Inclusion criteria focused on patients with critical limb-threatening ischemia, whom have suitable single segment of great saphenous vein, and suitable for surgical and endovascular interventions, with the stratification by clinical status and anatomical disease. Ethical consideration. The protocol was approved by ethics committee at each participating site. Patient consents were obtained from the trial at each participating site. Statistical analysis. Kaplan-Meier estimates and Cox proportional hazards models were used for time to event outcome. Kaplan-Meier estimate is the statistical method used to estimate the probability of survival over time. Cox proportional hazards, it assesses the relationship between survival time and one or more variables. P-value were reported for comparisons. Key findings of the study. This table is about 3 years measure amputation rate in cohort 1 group according to the anatomy of the arterial lesions by Kaplan-Meier estimates. It states that combined femoropopliteal and infrapopliteal disease is associated with higher risk for major amputation compared to femoropopliteal diseases alone, particularly in the surgical group. The surgical group B value equal 0.012 show better overall outcome with lower amputation rates. Compared to the endovascular group, B value estimated 0.093. And this table shows the association between time to major amputation and risk factors in cohort 1 group using Cox model. States that surgical treatment offer a protective effect against major amputation. Patients with comorbidities like diabetes mellitus or end-stage renal disease are at significantly higher risk for amputations. Smoking history don't show significant association with major amputation risk in this cohort. Funding resources, federally funded by the National Heart, Lung, and Blood Institute at the National Institute of Health. Novo Nordisk Foundation. Thank you.
Kindly, Dr. Omar Asad, go
Shall we talk about now? Shall we talk about our point of criticism? Start with the point of strength in the study, frame of the study.
Kindly share the screen before. Kindly share the screen before. Sharing screen.
Can you share the screen again, Dr. Khalid, to see the presentation of Dr. Omar Asad?
Okay.
So we'll use share screen from Dr. Khalid, but the one who will speak is Dr. Omar Asad. You can speak now, Dr. Omar, about the strength of the paper. Dr. Omar, can you speak? Dr. Omar Asad?
I'm sorry about technical error.
It's okay.
So now we are start to talk about our point of view of criticism. Our point of criticism about this paper. Point, weak point of point of strength in the study. The large number of patients and the long time frame of the study. Follow-up of cohort 1 group continue to 2021. Weak point of the study. The study isn't original. The first paper published in 2016 in the Journal of American and Heart Association. Another paper published at European Journal of Vascular and Endovascular Surgery in 2024. The inclusion and exclusion criteria of the patient not mentioned clearly in the paper, only referred to another papers that have been published elsewhere. Not all patients have the same risk factors. For example, diabetes mellitus, end-stage renal disease, smoking, which affect the net result of the study. Patient selection is very bad at the rate of the amputation between wrist pain versus infective gangrene, more towards the infection before revascularization. The way of randomization wasn't clearly mentioned in the study. The multicentricity is not a good choice at the patient to not in the same circumstances and not all study both physicians and the patients are aware of procedure that is not matched with randomization. The study isn't appropriate the broad field shape between different types of vascular lesion and its anatomical sites with a suitable revascularization options according to task classification. The study design isn't logic and sensible. There is this against standards of ethics and governance. As consenting patient for surgical bypass who has a tibial vessel disease is against the standards of ethics, the best option is endovascular revascularization according to task classification. The number of the patient is not equal in both cohort groups. The Kaplan-Meier estimate is a statistical method used to estimate the probability of survival over time. It is better with case control study, not cohort study. The study design is based mainly on comparisons between two cohort groups, but the early cessation of cohort 2 group and the unequal number of patients make it improperly implemented. The investigation used in the follow-up not clearly amputation, below ankle amputation for the patient to not end either due to infection, ischemia, or insufficient debridement. Limitation of the study: lack of blinding, early cessation of enrollment on cohort 2 due to funding problems. Patients in cohort 1 were followed at the end of October 2021, and those in the cohort 2 were followed to the end of 2019. Conflict of interest. Authors disclose the relationship between relationships with industry and the funding resource. For example, National Institute of Health and the Novo Nordisk Foundation. Conclusion: it is not advisable to depend on the results and recommendation of this study, and we recommend another papers and studies with more specific inclusion and exclusion criteria and the specific vascular lesions.
Thank you, Dr. Omar, for this presentation. And I'd like to have the participation of my professors, Professor Khaled, Professor Adel, and Professor Omar Farouk for discussion with the presenters, if they allow us. دكتور عادل قمحاوي. دكتور عادل.
أول حاجة أنا سعيد جدا 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 بالتفكير النقدي ده. critical thinking دي حاجة كويسة ومفتقدينها، والواحد ما كانش يحب كل واحد يسمع حاجة يؤمن بيها على طول. فأنا هابي جدا بطريقة التفكير دي، وكل اللي اتقال قد يكون صح وقد يكون غلط، دي كلها آراء وقابلة للنقد، ما هيش حقائق، ما عندناش فاكتس، لكن احنا بنناقش opinion. فأنا إذا كنت هركز على حاجة مش هركز على علم، هركز على حتة صعبة شوية وهي الاستاتستكس، عشان ما حدش هيتكلم فيها إلا أنا. الكابلان ماير ده هو كان احسن حاجه للحكايه دي، هو نهايه ايفنت. يعني الشباب بس اللي يعرفوه، لو واحد راكب قطر متجه من القاهره الى طنطا، فهو هيعدي على طوخ هينزل منه 2، هيعدي على اليوب هينزل منه 1، هيعدي على بان هينزل 5، لغايه ما يوصل طنطا نشوف هينزل كام. فهو بالايفنتس نوت باي ذا تايم. فهو اند اوف ذا ايفنت، قد يكون امبوتيشن، قد يكون ديث، اني اند اوف ذا ايفنت. فهو في الحاله دي هو الامبوتيشن. فالامبوتيشن حصل امتى؟ قد يكون حصل بعد اول شهرين، وبعدين حالتين تانيين امبوتيشن بعد 5، فالكيرف بيبتدي ينزل معانا. فهو حسب نزول الناس من المحطات، او ان احنا بنحسبها بالتايم. القطر ده من القاهره لطنطا هياخد ساعه ونص، فاحنا كل تلت ساعه هيكون نزل قد ايه؟ مالناش دعوه بالمحطه، خد بال حضرتك. فهو بس علشان نفهمه الكيرف ده هو مناسب للاند اوف ذا ايفنت، حاجه بتكون فليكسبل وممكن ان احنا نحسبها بالايفنت. الامبوتيشن ده حصل بعد اسبوع ولا بعد شهر وعددهم كام، ونشوف النتيجه بتاعتنا ونقارنها. قد تكون المقارنه غير عادله، لكن انا بتكلم بس على الاستاتستيكال كابلان ماير سرفايفل تيست. ما هوش بس ديث، لكن اند اوف ذا ايفنت وات ايفر ذا اند ايه. ممكن نحسبها بالتايم، ممكن نحسبها بعدد الايفنتس اللي بتحصل. لكن انا سعيد جدا باللي اتقال ده. شكرا.
الف شكر لحضرتك. many thanks for Professor Adel Kamhawi, and let me ask for the question by Professor Khaled Abdelal. He was raising his hand. Yes, sir.
Yes. أول حاجة, thank you very much. It's very interesting to have a brainstorming together. The purpose of the meeting is to discuss the paper from all its ways and then make the criticism or the complementation. But you omit to tell us what was the paper. I didn't hear a single percentage of the paper, the results that you have criticized. So for the audience that are available now, they don't know what you are talking about and what was the result of the paper, how they designed. You have made a general criticism because you have read it, but we did not read it. So I think we have to start by exposing the paper, explaining the paper, explaining the cohorts, how many patients were diabetic, how many patients was chronic renal disease, the amputation rate between the two groups, and then you will do your criticism, what you find strong, what you find weak. This paper, despite of it is a repeated paper, but it is very important because it is the first paper speaking about the major amputation, comparing the one segment revascularization and endovascular. For me personally, after so much years of experience, more than 36 years, I was in my mind convinced that the rate of amputation with endovascular is equal or maybe better. But this paper proved that maybe I am wrong. That means if you use a single vein and you do a bypass, you will have rate of amputation less than endovascular. We need to know why. That's why it's very important you expose the paper and then try to answer this question. How come that vascularization will have a better outcome compared to endovascular? And second thing, there is another part, the cohort 2 that was stopped. It was the multi-segment use of great saphenous vein. And this will agree that if you use a single vein for revascularization, it's much better than you use two parts of vein or part of vein and part of a graft. But you have to expose this in order so that all the attendees will understand what happened, what was the study, and try to get a benefit and then listen to your criticism. Thank you anyway. It's a very good start. And I hope next time we'll develop more the paper and then make the criticism later.
Thank you, Professor Khaled. But before I have the talk of my Professor Omar Farouk, I want to ask the presenter that did you fulfill the points that Professor Khaled asked about it, about the paper? What you understand or what you implement from reading of this paper? Dr. Khaled, please.
Yes, Dr. Mustafa. In this paper, we can't reach to the inclusion and exclusion criteria from which the authors do this paper. It's only two reference. We're searching for these two reference, and we can't get nothing for the inclusion and exclusion criteria. And to go furthermore with diabetes, renal end-stage renal disease, smoking, and this is one of the weakest point of the study.
Dr. Omar Asad, if you have another comment, please.
Multiple defects were found in this paper, as the patient from Rutherford 4 to Rutherford 6, patient with wrist pain, and the patient with tissue clean ulcer, and the patient with gangrene, either dry or infective gangrene, were randomized to two groups, in the cohort 1 group, either surgical bypass or endovascular revascularization. With the risk factors, it is not standard in all patients. Some patients have end-stage renal disease, some patients have diabetes mellitus. Not all the patients have diabetes, not all the patients have end-stage renal disease. So multiple results will found at the end, and it is not sufficient to compare endovascular revascularization and surgical bypass for the net results about the major amputation.
Excuse me for interruption, but what would Professor Khaled ask about it? Did the author enumerate the number of patients with diabetes, end-stage renal disease, how many patients going for minor amputation, how many patients going for major amputation or death? Did he enumerate this?
No.
Okay.
After finishing the study, a diagram was made by Cox recognition that the diabetes mellitus increased the rate of major amputation more than the double, and the end-stage renal disease increased the rate of major amputation more than the double, and even the smoking have no effect on the major amputation, even the patient several years of smoking or even not smoking at all. So
what I can conclude from your opinion, that the author didn't include the risk factors, didn't enumerate in each group the number of patients that have this risk factor, didn't include the age of the patient, didn't include the sex of the patient, didn't include the arterial lesion that affected the patient, and he directed them for either surgical or endovascular intervention without identification for the type of the patient and which intervention is much more suitable for them. This is what I can understand from your comment.
Yes, Dr. Mustafa.
Okay, Dr. Omar Farouk, if you please, we need your.
Bismillah ar-Rahman ar-Rahim. Thank you very much for this is your project with the club, Mustafa Shal. And I know that you have passed the European Board of Vascular Surgery. And it's a very good initiative, because I think one of the major defects that we have in our teaching in Egypt overall is paper analysis and paper criticism. And paper analysis is important in FRCS discussion, you present it with paper, and also in MED vascular surgery, both Ain Shams and Qasr Al Aini Hospital. So let me start little by little. I think number one, as Professor Khaled said, we should present the paper to us. As far as I know, it is analysis of an arm of a patient from the best CLI paper, which is very well known. So this is subgroup analysis. He did not take this as a study of his own. No, he just took the number from best CLI with randomization to surgery with a good vein plus endovascular. This is number one. Number two, it would be nice to present the paper shortly so Professor Khalid can be on board. And I know that your brochure, you already put the paper itself, but sometimes people go without previous reading to the paper. Number three, I think the criticism of Dr. Omar was very tough. And don't think that if you are very tough in your criticism, you get a higher mark, because the examiner will tell you, okay, tell me how many papers have you published? Because this paper have been published in the European Journal of Vascular and Endovascular Surgery in 2024. It's a very eminent paper. And during your criticism, I think the source of your criticism is your own. Is that right, Dr. Omar? Yes, it's your own. Because, yes, you did criticize an ethical committee. And this is a big deal. When you say to someone in the United States, your ethical committee cannot know ethics well, this is, it's not right. And this paper was actually the patient by NIH. NIH in United States, it is like the Bible of vascular surgery. This is the finest people of research. So I actually have put this paper into Google called Notebook LM. And I told the Notebook LM what are the defects in this paper. He mentioned 5, none of the things that you have said, but it was very logical criticism. So number 1, don't criticize ethical committee of another hospital that you don't know of. This is number 1. Number 2, you criticize NIH. NIH is not to be criticized. And you can say, well, I felt that the paper is weak in so and so and so, but you can say it nicely, politely, and you get marked by this. I think you were too aggressive in your criticism. And if you see the author, each author have a number of Q1 paper publication. I did check all of them. None of them have less than 25 Q1. Q1 is paper that has been published in journal with an impact factor more than 5. So if you put yourself into criticizing these guys, either you have 30 or more paper of Q1, which is published with an impact factor more than 5, or I can say, in my opinion, from my humble experience, I think this is important because you get marked how you criticize a paper in a professional way. But I think he went a little bit too far. If I was the examiner, I would have taken tough on you. So ethical committee in the United States is one of the best in the world. It have approved the ethical committee. There is a lot of defect because he did not say that I have done this paper, the author. No, it took sub-analysis from best CLI, which we know is a big study. And we know all clinically, if you get a good vein and you do film distal bypass, you get perfusion, which is beyond any endovascular mean. This is logic. But he did not say what is a good vein. He did not say what endovascular option, as he has used which type of stent. Was it third generation nitinol stent? Did he use drug-eluting technology? He put all endovascular into one basket, and I can criticize that. And he put all open in one basket, and also can criticize that. The reason he has discrepancy, he said that his endovascular arm was underpowered because the number of cases was less than the long vein. So you can see the defect that he already mentioned. There is also one thing that you mentioned. You said conflict of interest. There was no conflict of interest because he declared that he working in NIH and working in the other company, but regarding this paper, there is no conflict of interest. So this is important because if you tell him that, well, you've been nasty, you take money to say so, No, this is consider with professionalism to be suboptimal. So it's a very good exercise. I congratulate Mustafa Shal. I hope he continue this activity every month. It will definitely improve our understanding of paper and how we can criticize. And I will mention to you one of the great artificial intelligence tool that would help you to how to criticize a paper, which is called Notebook LM. You can import the paper, then you have a discussion as if you have a discussion with the author. Explain everything, explain statistics, and Professor Adil Amhawi said. So it's a very good exercise. I'm sure a lot of us have benefited from it. And it's good that you start your criticism at this level, but I would just my advice to Omar, get little bit slower, don't that aggressive, unless you publish 30 Q1 paper. Then I would say, okay, you are entitled to do that. And for Dr. Khalid, it was very nice presentation. I did like very much the point you put in the beginning, because this is how you analyze paper and read paper. And the more paper you read, the more analysis you do, the better you are when you're doing paper to avoid these mistakes. But this was a big paper. They spent millions and millions of dollars to get follow-up for 1,400 cases in one arm and 300 the other arm. This is huge. And you get approval of NIH, approval of FDA, approval of ethical committee of at least 7 hospitals in the States. So take it slowly, take it a little bit easy. And it was very enjoyable meeting to everyone. And back to you, Professor Mustafa Shah.
Thank you, sir, for this illustration, which a lot of us may have a lack of this information, but not our Dr. Omar Farouk. And I'd like to say to you, sir, that if I have a 30 paper with Q1, I will not speak to any one of the humans.
Professor Khalid raised his hand.
Yeah, thank you very much. It's I will not add something more, but I want to take the benefits more than the exposure of the paper. So I shall ask the two representatives, if you are the one organizing such a study, comparing the amputation results, the end result as amputation for a patient revascularized surgically and patient with endovascular, how you will design the study. I'll tell you what I think later on, but I wish you to have the idea, if you have 1,800 patients and you want to compare the end result as amputation between the surgical and the endovascular, how you will divide it, what is your design?
Yes, Dr. Omar, please.
I think case control study.
So just I want you to exteriorize all what you have in mind. This is the purpose of our meeting, that you'll have more ideas so that you will have more wider thinking.
In my point of view, case control study will help us to define the best treatment of vascular ischemia. After collection of this patient, we will reach the patient undergo major amputation, and then case control retrospective collecting the data about the risk factors and the type of the operation done, either endovascular or surgical bypass, and then analyze this data to reach the best treatment, which of one endovascular or surgical bypass have a higher number of amputation with these risk factors.
Okay, Dr. Omar, what about the dividing or creation of a third group by the hybrid technique? What will be your opinion?
Very good. As this type of intervention hybrid technique not mentioned in this study at all.
And would you what the type of the patient that will you categorize him in this group, from your opinion?
risk factor, patient have risk factor smoking and diabetic, and the patient task B and task C will be good for this study to compare about totally endo or surgical or hybrid technique.
Okay, Dr. Khaled, please, your opinion, please.
My opinion, we can lower the total number of cohort 1 to be equal to cohort 2 to be suitable for net results, equal net results, and can follow up the two groups. We must clarify inclusion and exclusion criteria from start in detail. We prefer for this study the retrospective design for more detailed results. And we must mention the tools of follow-up and tools of investigation for the long-term follow-up of the patients.
Okay.
Thank you, Dr. Mustafa.
Our Professor Khaled, what was in your mind?
Well, I'll tell you what I'll do, because this was a training that we used to use when we were young students in France. That means the most important things that you gather is the information. And once you have big number of information, you have a mine of diamonds. You can explore to the deepest points. So I think if I was me who will make the design, first of all, I will divide the patient according to the level of the lesion. This is patients all having critical limb ischemia. So what are the lesions situation? Is it at level iliac, femoropopliteal, infragenicular, or combination between both? This will be the main group, so it will be divided according to the site of the lesion. In each group, I will make subdivisions. The patient, how many diabetic, how many with end-stage renal disease, and what was the stage before revascularization. If you have a patient with critical limb ischemia with stage 3-4, or a patient with infection of toes starting gangrene, what is the level of the TCPO2 before revascularization? If the TCPO2 is 10, is not like 70 or 60. So if you wanted to compare, you have to compare with adequate information before in order to compare the result after revascularization. If you have a patient, for example, with a combined lesion, iliac and femoral and infragenicular and gangrene of the toe, severe infection with cardiovascular manifestation and stage renal failure, of course, the rate of amputation will be much higher than younger patient have diabetic and only single femoropopliteal. So you cannot gather all the patients according to a generalized lesion. So in my opinion, first of thing, we divide according to the site of the lesion, and from each side of the lesion, we divide subgroups for the type of the patient that we have faced in this group of lesions. And we cannot compare between the lesion, not the iliac, not the infragenicular, not the combined iliac femoropopliteal. And second thing, what experience of the operator? That means the young generation now are more at ease with endovascular. So if I ask one of the youngest generation now who is very brilliant in endovascular to make a femoropopliteal bypass, he has perhaps maybe 5-6 number of bypasses doing per year. Not if I compare with an old surgeon having 200 bypass done and fewer endovascular. So I think we have to also to evaluate who is doing the surgery and who is doing the endovascular. And we cannot compare the one who is expert endovascular and not expert in open surgery with the one who is expert in open surgery and not expert. And second thing, what about the post-operative? That means these patients we have operated, part surgically and part endovascular. How many patient has primary patency for 5 years? How many patient has restenosis? What we have done with this restenosis? Is the restenosis in the open surgery is more than the endovascular or the opposite? Did we need to do open technique with stenosis in open patients, or we did endovascular? There is lot of data, lot of analysis, and I think if you have 1,800 patients and you have all these elements, you can make 6 or 7 papers regarding the quality of information that you gathered. That's all I want to add. Thank you.
Thank you, Professor Khaled, for your kindness. And I'd like yes, Professor Khaled, Professor Abhawi. Professor Kamhawi, please.
Thank you, Dr. Khalid. You highlighted a very important points. Also in the research, we must differentiate between association, مصاحبة, correlation, ارتباط, and explanation, التوضيح. As we know, in critically ill patient, we prefer endovascular, but lifespan of the patient is short. So we cannot say the end result of endovascular is short lifespan of the patient. It is association. It is not a correlation. It is not an explanation why the lifespan of the patient is so short with the cases of endovascular intervention. So to avoid bias, we must differentiate between association, Cox correlation, الارتباط, and explanation of this event. Thank you.
Thank you, Professor. Thank you, Professor Kamhawi, please. Thank you very much. And now we are 43 minutes of scientific discussion, and I'd like to ask to my professors if they have any comment for the presenters.
I think
And
it's
later-
good done. Yeah, and you're
Yes.
very well done. And try to elaborate from your type and try to be creative. And as Dr. Muhammad said, it comes by time and experience, but it's a very good start. Thank you very much.
Yeah, thank you, Professor Khalid. Dr. Omar? Dr. Omar Farouk?
Thank you very much. It was definitely one of the weak points that we have in our teaching in Egypt. You did highlight how we can read the paper, how we can learn from paper, how we can criticize paper. I would also add using artificial intelligence in the way you understand paper is very beneficial. We know how to criticize with professionalism, and we know how to grab the information. Professor Khalid Abdel said how to grab data, how to squeeze data, and how to use this data in manipulation. I definitely expect a very good vascular career to Dr. Khalid Muhammad, to Dr. Omar Asad. It was a good start. It was an excellent start. And we hope to see them with more paper of their selection and your selection. Professor Mustafa Shal, you did touch a very nice topic, a very important topic. And let me just end by one sentence. This month, the paper published in Medicine in China is more than what is published from United States. They have now crossed 15,000 paper published per year in China, more than United States. And let me end by, in Israel, they publish more paper in medicine and surgery than the whole Arab world publishing. So there is a duty to any one of us. We know that we don't have registration fund or research fund in our country, but this is not an excuse not to try to publish. It is our duty, our obligation to be there. If you compare the number of my country with the rest of the country in publication, you feel that we have a long way to do. And thank you very much.
Thank you, sir. Professor Kamhawi? Your last comment, Professor Kamhawi, please.
Dr. Mustafa, I appreciate this effort, young generation to present the papers and present the data and criticize the data. This is a very good work. It is a start, and the end of this way will be something great. Thank you, Dr. Mustafa. Thank you very much.
Thank you for all my professors, and I want to inform that we will have this scientific journal club every month, inshallah, and within the next week I will announce about the meeting of January, and for sure I can't get away from your kindness and your knowledge, my professors. Thank you for Dr. Khalid Muhammad. Thank you for Dr. Omar Asad, and I hope that you know what our professors say about how to criticize a paper. Thank you for all the attendees and audience, and thank you for Masra Al Fain for their great effort for this webinar. Thank you very much, and